So 11B is kind of the opposite of what 11A was. 11A, we looked at the case study, and that case study looked at a condition or disease as the case of interest across multiple people, across multiple cases. There was no causality, it was just descriptive. Here, when we do causal comparative research or case control studies, we're getting more into assigning causality and looking to make sure that if we think one variable or one factor causes another, that it actually happens. So the prior case series you can think of as more exploratory, and this is definitely more looking at causal ordering or causality. Does a independent precede dependent variable, and are there other extraneous controlling or confounding variables, other variables that are kind of in that relationship that we're not aware of? So, right, this is exactly it. We looked at correlation or association, and now we're looking at a causal relationship. So if we give people a drug versus a placebo, we want to see that independent variable, depending on which they get, does that improve patient's illness, right? The dependent variable. And that sometimes we can't give a drug or placebo. Sometimes we can't give an experimental condition and standard of practice. So sometimes we don't have that ability to do it. So we end up doing something that looks like a case control, right? We can't manipulate access to treatment. So we look at a case control, or we look at a cohort study. So we'll go through it. So right here, you see there's GPA of students with abusive childhood, right? If you think of this concept of life course, or things that happen earlier in life affecting one later, having a childhood home that's disruptive, can that affect GPA? So we're going to use a causal comparative design, and it plays out this way. You find out teenagers who come from homes that were identified to be abusive and non-abusive, and then you compare GPAs, right? So causal comparative. So you're looking at the same outcome, what's the GPA, and you're looking at two groups that naturally exist, but you're not assigning groups to any sort of control or abusive, non-abusive. Those are things that happened. So it's a causal comparative design. And things that you cannot manipulate or change, right, ethically, you of course can change age or socioeconomic status, right? You can't assign people to a group of elite or poor, right? This is unethical. You can't expose people necessarily to a health condition, right? So that's something that you can't do. That's unethical as well. You're not going to manipulate a psychological trauma. You can see if there was an exposure to it, but you can't manipulate that event. And then think about healthcare, access to prenatal care. I worked for many years in an OB/GYN clinic when I was the HIV counselor, and health insurance unfortunately does this, but we know there's inequity in access to care, but we cannot create inequity and access to care for women who are pregnant in terms of healthcare availability or options. And then we can't control or change family environment. So family affection, family violence, dual income, any familial characteristics, we can't change, right? These are obvious, but these are things that we cannot, thank goodness, change. So what do we want to do? In this causal comparative research, we're going to look for existing differences, right, that affect an outcome. So we're not creating differences, we're looking at what are those differences, right? So two communities that live in the same area that are present when there is a hurricane, right, or some natural disaster, one community tends to be wealthy, one community tends to be working class. We could look at the impact of the causal comparative study of the impact of that natural disaster on both those communities, but we're not adjusting anything, right? We're looking at the differences, existing differences. And again, remember, we're looking at group membership, which is always 0-1. So are you a part of the group that has been exposed to this? Yes, no, right? Yes is a 1, no is a 0. And it's an independent variable. So maybe social class in that example is your independent variable, leading to, your recovery post hurricane. But we're not saying that we are grouping anyone or we're changing people's social class, right? So we look at existing relationships and we draw a sample from them. So we could look at people who have Lyme disease and those who don't, right? Those are people existing in the community. People who get mammograms yearly and people who don't. Older adults who live in the community and older adults who live in care. These are groups that we're not constructing. These are groups that we're experiencing in society. Maybe your clients who attend every appointment and those who miss appointments, right? You're not intervening, but you know that there are people who do that. Clients who maybe follow up on whatever instructions you provide and clients who don't, right? Those are not groups you're manipulating. Those are groups that exist in your practice or your profession. Oh, excuse me, sorry. Sorry about that. I was just drinking water to try to battle the construction dust. So again, not only is there group assignment, but there are many things like that exists in reality. So looking at people's social class and experience of a natural disaster, we know there's more than social class. There's gender, there's race, there's family size, there's household income, right? There's education level. So there are many other variables that we look for. So here's an example of a way you would make a hypothesis. So people who received early childhood intervention versus those who did not, right, receive intervention are less likely to have cognitive decline. So of course I'm looking at cognitive decline in in people, right, in older adults. And I want to go back and look at early predictors. So I never assigned anyone into those who received like Head Start or any kind of reading or intervention programs. But in society, some people receive those programs and some people don't. So it's a natural way to do a causal comparative study of children who went through a Head Start or early intervention programs and children that didn't, and then looking at them later on, maybe 60, 70 years, and seeing, what's their rate of cognitive decline, which is the outcome. As we know, there are also many other variables that affect cognitive health, but we're interested in what's that early intervention relationship. So how do you do it? Like, what's the way you really kind of organize your study? So you decide 2 groups that are different on a grouping variable, right? So the difference would be early intervention status, maybe exposure to Lyme disease, socioeconomic status, whatever that is. And then you collect other variables. These are extraneous variables and others. And then you look at the dependent variable. So in this example, my 2 groups are those that had childhood and early intervention, yes or no, right? Yes or no. And then I'm looking at other variables like their current age, their gender, their education, maybe exercise level, all of those things that may impact cognitive health in addition to an early childhood intervention. And then my outcome is looking at how all these things impact cognitive status. So you see in this causal comparative research, you see that we're really looking to generate cause and effect, where in the case study or the case study series, we were not. And what do you do, right? We're not randomly assigning people because we're looking at these naturally existing groups. So we can pair match, right? Match people up. So people who have similar characteristics who did have early childhood intervention and those that don't, right? But their other characteristics are the same, so we can hold that constant. And the reason we kind of match people up is that we don't want to make a prediction and say, yes, it seems that early childhood intervention does give you an advantage and makes you more cognitively healthy, when in reality, it was the fact that everybody in that group also had a higher level of education. So we want to make sure, and one of our goals throughout the course is that if we think something's causing something, that it is. So if we think that an independent variable is causing a dependent, it has to. And just like the case study, right? The case study in the prior case study series looked at deeply at one disease process or one set of symptoms. Causal comparative research gives you a way to establish causality when you don't have an experimental condition. So we can't experiment and expose people and say, okay, these children will have early intervention, these children won't, and let's wait 50 years and see. So we're taking advantage of naturally occurring differences in the population, and we can actually use cause and effect. And we can control for other variables that might be in the relationship and we need to be considerate of. But in reality, we have limited control of the study. We're not randomizing people to groups. We don't know what other experiences people in the groups that could have that make them different. And we think that, that this early intervention that's really making people cognitively healthy, but in reality, it's income or education or being multilingual or exercise. So we run the risk of making a causal relationship that's not valid or that's not completely true, but we understand that and we keep that as a limitation because we do get some causal ordering from this process. So if we think about it, it's kind of in the middle, right? It's not correlational. So causal comparative research lets us do cause and effect. So it's beyond association, beyond correlation. But like experimental designs, causal comparative research in the middle ground, it doesn't let us really isolate and manipulate and control independent and dependent variables. We don't have internal validity. We can't control the independent variable because we can't control people's exposure to Lyme disease or whatever that exposure is. So we're in kind of the middle ground, but it's a nice middle ground. And then think about it when we're looking at causal comparative with experiments. Think of what I said. We do have the ability to do independent and dependent variables, but we cannot randomize, and we do not have that internal validity or control over all aspects in the study. So here's a fun chart, right? If you're interested in visualization and how to decide what to do, so you can look and say, okay, am I collecting new data, right? Yes. Am I doing an experiment? No. Do I have disease exposure or population? Yes. So I can do a case series or a case control study. So the case series is the first one we looked at, and then a case control kind of gives us a little bit more control over comparison. So it's good to look through. This is the case control. Right, so they all sound a bit similar. So the case series we did, right, that was the one that looked deeply at a case. Then we did the causal comparative research as a type. And if we look in causal comparative research, one type is a case control study. So we look at people who have a disease of interest and those that do not. And we can compare history. So we're looking at cases and control. Right? Do they have different histories? How do I identify cases? And then we would produce an odds ratio. So we can look back and say, we've found people with this particular disease, whatever it is. We don't know what led up to the disease, so we can kind of do almost a forensic kind of, or if the person's hopefully alive, you're just doing a retrospective view. So what is really exposure to that disease, right? We're interested in looking at, this independent variable of people with or without Lyme disease, but what led to it, right? What led to it? So we're testing this relationship that do we see that people with or without Lyme disease have spend more or less time in the woods, right? How are we seeing that relationship? And A cross-sectional study just looks at the prevalence of disease, right? A cross-sectional just says what percentage of people have Lyme disease, but it's not going to necessarily make this connection of cases and controls. And what are the potential biases? Right, there may be people that weren't exposed and we think they are, or people who are exposed and weren't. If we're looking back to see what makes someone's disease presentation different, we're relying a lot on recall, and recall is kind of tough, right? Thinking about past events and recalling them in order brings in an amount of error that we might not have. And then what we do at the end of this case control, we would say that if you're a case, your likelihood of exposure would be this much greater than somebody who's a control. But it gives you a risk ratio or an odds ratio, right? So being in the woods, maybe your odds ratio compared to those who don't go in the woods to access Lyme disease might be twice as likely. So you could find out that, you know, being in the woods makes you twice as likely to be exposed to Lyme disease, which gives you a way of categorizing that risk, right? We know that you're twice as likely. And here you see that they're looking at, traffic noise, right? And Parkinson's disease. And they're saying with air pollution associated with risk of Parkinson's disease, for participants that were greater than 20 years living in the city, their risk due to pollution was 1.21, right? And more than those in towns. So you're finding that when the odds ratio is over 1, it's a higher risk. So people getting people at Parkinson's, a risk for them was living in a larger city or living in a non-provincial town. So people who were living in areas that were more metropolitan would have higher risks of Parkinson's disease than those who lived in other settings. Now we're switching a little bit to cohort. So it's a lot of terminology and a lot of language. But think about it this way. When you are looking at a cohort, like when we say, what's your cohort in your class, right? Who's your cohort? A cohort is just a group of people that transition through time together, right? So people who move through birth cohort, you know, any sort of cohort, class cohort. And cohorts provide a really nice way of comparing, right? So if you're doing a prospective cohort study, you actually meet with the individuals, you collect data, and you follow them in time. So in a prospective cohort study, you can actually see the prevalence, or actually the incidence, the occurrence of new cases, and you can track the prevalence or cases over time, you know, in the groups. And you can do risk ratios, right? So what's the risk of being in one group versus another being exposed, right? Here's a study cohort. We look at some people are exposed to a factor, some people who are not exposed to a factor, and then we assess among the people that were exposed to the factor, exposed to this factor, how many people developed the disorder and how many didn't. In the study cohort, those not exposed to the factor, how many developed a disorder and how many didn't, right? We get a good image of what it's like among those who were exposed and not exposed, and see what their disease status is at the end. And this is really helpful when you read it in the articles that you're working on, right? This is data were used from the second manifestations of arterial disease, memory, depression, and aging study, a prospective cohort study in patients with a history of arterial disease, and the aim was to investigate how brain changes are associated with depression and psychosocial vulnerability and stress factors. So what happened was we entered the relationship with the group, and then you're tracking them. So they have this arterial disease, we're going to track them and see how these cohorts move through time, and then who develops depression, psychosocial vulnerability, and stress over time. This is a way to interpret an odds ratio that is for these groups. Increased risk for, oh, I'm sorry, that should be depression. Increased risk for chronic course of depression was observed for patients with cerebral vascular disease when compared to patients with coronary artery disease. So people who have cardiovascular disease, CVD, their risk of depression was 2.5 times greater than those who just had coronary artery disease. So you're saying within these two groups, there's different risk of depression, and here's how we quantify the risk. In CVD, that risk is 2.5 times greater than it would be for those who just have coronary artery disease alone. So I rolled through these designs kind of quickly, and sometimes they blur together a little bit. So I ask that you take a few minutes, a couple minutes a day or a couple minutes at a time, and just read through, understand what that study is like, what the goals of that particular design are, and then what the strengths are, what the limitations are. And when you read it in a journal, go back and think, is this the correct approach for that research question? I hope you all have a good week, and I will see you in the announcements. Take care.